Perfect. Welcome, everybody. Our quick reminder for those of you who like to use closed captions, they are fully implemented in Zoom, and here are some directions for how to do it. And if you experience trouble, please put in the chat, and Cora and Alli will help out with that. Next slide, please. All right. As a reminder, we are here because we are funded by NIDA to advance the science on recovery community centers. And this is a great group of people behind the scenes who is the brains behind the operation to steer our seminar series and all of our other initiatives. So huge thanks to everybody on the slide and all the other people too. Next slide, please. We are part of a larger consortium on addiction recovery science, and this microfiche slide lists all the kinds of opportunities that there are for collaborating on science in this space. We will mail out these slides on Monday. We will also have them on our website, so you can read the microfiche at that point. We just wanted to highlight things like open opportunities for pilot funding via the print network. There is a paper, a special issue in Frontiers of the Public Health, where we are still accepting papers for, and there are opportunities for participating on community boards. I don't see a postdoc one this time, but there's a paid internship position in the JEEP initiative. So please browse this for a number of opportunities that exist for doing research and collaborating research in this space. Next slide. We are also, as always, updating our list of recovery community centers. Since we do a lot of work with recovery community centers, people will reach out to us and say, do I have an RCC near me? And that's why we want to have this list. The list is on the website, and Alli is putting the link to our currently active list there, sorted by state. So if you're looking at this list and you don't see your RCC there, or you look at this list and there's an RCC not listed that you know of, we very much appreciate a quick email from you all so we can add that RCC to our list. Next slide. People then also ask us if they want to connect for research projects, and we also put that here. So one of our pilot study teams, led by Dr. Davida Schiff, is currently recruiting people who are working at recovery community centers. And here is the information and the barcode if you want to fill out a form there to inquire about participating in their study. Next slide, please. All right, and that brings us to the live feature. As you know, we always want to start our seminars by grounding ourselves in what are recovery community centers, what do they look and feel like. So today we have MIFA's Todd Fowler and Darci Pickett from the Serenity House communities, and they are going to tell us what happens when you walk through the door of their RCCs. Todd, I think you're going to start. Over to you.
Thank you. Well, good afternoon, everyone. My name is Todd Fowler. I am the peer recovery coach and supervisor at Serenity House Communities. Serenity House Communities is a 501c3 nonprofit RCO. Serenity House Communities offers the holistic options for people suffering from substance use disorder, trauma, and codependency. We have two locations, one in Flint and one in Lapeer. The Flint location is located downtown Flint. This makes it easy for people to be able to walk in off the streets to get services. Our office here in Flint used to be a house that we turned into office space. We want our participants to feel that homey feeling when they enter the Serenity House. Our Lapeer office is located in a business complex. This is a smaller office. It is clean and suitable for our coaching and groups. Here at Serenity House Communities, we offer peer recovery coaching services. We have both men and women coaches. We also hold various groups throughout the week. We have a youth group on Tuesday. We have an AccuDetox group on Wednesday. Thursday, we have a men's meditation support group, and on Friday is our women's self-care group. Saturday, we also offer 3 groups back-to-back. They are yoga, AccuDetox, and recovery Reiki. At our Lapeer location on Wednesday, we do an EFT, and on Thursday, we have a guided meditation group. Our vision at Serenity House Communities is to create a community free of substance use disorder, trauma, and codependency. We also do all kinds of events throughout the year, which I will pass this over to Darci. She is our event coordinator. Thank you.
Hi, everyone. Thank you, Todd. My name is Darci Pickett, and I am the Community Development Coordinator at Serenity House. Todd touched on all of our amazing free services to help support those in recovery, to be that community. We also do numerous free community events throughout the year to give back. For example, we just held 2 trunk or treats at each Lapeer and Flint location. Our Flint event alone had over 900 people. We also host an art and recovery event in May, our recovery walk and rally in September, which is recovery month, and we want to honor that. We even hosted a holistic health fair where we offered free B12 and vitamin D shots, holistic food, AccuDetox, and Reiki. We also do sober socials for our participants the last Friday of every month. These again are free to our participants and whoever wants to attend. They have a fun night, network, and come together and with others in recovery. We are having a shamanic journey, for example, for our sober social at the end of this month. We try to offer not just fun, but healing events where participants can treat themselves to an experience they normally wouldn't. Thank you so much for having Serenity House. We get to see the good every day that RCOs are, or RCCs, and we're blessed and thankful to be a part of that. Thank you for having us.
Wonderful. Thank you, Darci and Todd. And that is a great way for us to get grounded. Perfect. So you can go to the next slide, Cora. And as you all know, we're always doing polling questions to find out who's in the room, as well as to cue the content that's about to come. So for this poll, thank you, Cora, for starting it up. Actually, is it Alivia or Cora doing this? One of you guys is doing it now. Perfect. If you guys can answer these things, so just kind of like click on these buttons, and then there's a gray thing on the side that you need to drag down to get all the way to the end. And when you've entered all the questions, there should be a blue button on the bottom right that says submit. And once you click that, that poll window should go away. Are we looking for completion rates, Alivia?
We just passed 60%.
All right, we'll go till 80%. Or until the seminar ends.
We just hit 70.
All right. Cora, I think you have a...
It's not Cora.
Oh, it's not, okay.
Yeah, we're at 75%. Do you want me to cut it?
Very good. All right. You can click the close button, and now everybody can see. Oh, you're viewing the results shared by host. Perfect. So everybody can scroll through it. So I'm going to go to the bottom, and see what the answers were. So we asked you all, what percentage of opioid treat program directors do you think know about RCCs? And the consensus in the room seems to be that roughly half of them would know about them. And then the next question, we were more targeted about the RCC that's down the street from them, about 9 miles away. And most of us thought that about 40% of RCC directors would know. But we had pretty spread answers for that one. All right, and then we wrote the barriers. Let me see. The barrier that we think would be most commonly expressed by clinic directors. 75% believe that simply not knowing if RCCs will be able to help the patients would be the number one barrier. And then 63% of us believe that not knowing enough about RCCs in general, about who they are and what they do, would be a number one. But all of these barriers got lots of endorsement from all of us. All right. So keep those questions in mind and see how our results match up. If you go to the next slide for us. All right. We have a whole number of upcoming seminars scheduled, so we just wanted to let you guys know this will be in our email to you, but you can basically register for all the seminars coming up from now until the end of April. And these are going to be all data heavy. They're going to be our pilot study teams that are going to be presenting back about how their pilot study projects worked. This is starting the new year. And in December, we will still have a special guest speaker who's not a pilot fundee, Dr. Iyoma Chara Abrahams, who's going to be sharing the outcomes of focus groups she did with the Massachusetts Recovery Community Centers. You'll see here that the schedule is packed. We're going to have double events in March and double events in April. Since we have pilot studies in the field, we want to make sure that all of them get the full hour and your input on what they have found. All right, next study. Next slide. All right, I'm going to just give you the feedback that Vinod Rao was with us today. He will serve as our discussant to kind of reflect on what our study findings mean from his perspective as a medical director of ambulatory psychiatry and the medical director of a West End clinic. Next slide. For our main presentation, we are going to have a whole number of speakers today because we all are taking different slides that we are presenting. We are very excited to share with you all the outcomes of a small piece of a larger project that we are engaging in together. And in this particular study, we asked the question of, do clinics that are providing medications for opioid use disorder know about their local RCC? And we surveyed these clinics, and for some directors, we also did an interview. Next slide, please. These are the presenters that you will be hearing from today. We will always show in the top left corner who is currently speaking. And you can see we're going to be playing musical chairs with our slides. Next slide, please. Our outline for today is that we're going to spend some time setting the stage for you all. We're going to relate the findings we are showing today with what happened back in Seminar 5. Then we're going to give you a little bit of history about how this team came together to do this research together, and the information that motivated us and the specific design we picked for it. After we've set the stage for you all, we're going to get into the nitty-gritty. We're going to be showing our design and our specific findings. And then we're going to have some questions for you all in terms of things that we want to know from you and would love to get feedback on. Of course, always feel free to speak up in the middle too and ask your questions as we go. Next slide, please. All right, so how many of you were here for Seminar 5? That was back in March of 2021. And at that point, we did a moderated panel discussion with people from Mass General Hospital. I see Marcus's, at least I think it is, which is wonderful. We had folks from Massachusetts General Hospital, which is where our academic team is based, to find out what is the divide, or how do you best bridge the divide between the healthcare system and recovery community centers. And one of the striking things that we realized in that moderate discussion is how little people in the healthcare sector know about recovery community centers. And that's when we started implementing our live feature, which Todd and Darci beautifully did for us a little while ago. And we also decided to do some research on this, which brings us to the next slide.
Hello. So what happened next was we all participated in a survey. There was a nationwide survey that our 24 team did, and DRP, which I'm a part of, and Nora, and later Pillars all participated in that survey. And then NIDA had an opportunity come up, which was the HEAL initiative, and it was announced in December of 21. We all got together along with MGH and we worked on writing the grant proposal. It was submitted in March of 2022. It was funded in September. And Felicia Pullen from Pillars joined us, and we're doing the work. So thank you, NIDA.
Perfect. Next slide. So here is our team. You can see we are from 4 different organizations. We have 3 RCCs and 1 academic team, and we collaborate on every piece of the project together. Today, we're only going to be showing you results from 1 study. In total, there's 3 studies in this project. And we do have different responsibilities in terms of how we collect the data, how we recruit study participants, and so forth. And a lot of the nitty-gritty of designing the electronic databases and going through the logistical steps of running a study and analyzing the data. A lot of that happens at MGH, but for all of our team, we chime in together on what questions should be asked, how do we resolve problems as we encounter them in recruitment and in data as we are seeing it. We are refining our methods as we go along. And then once we get data, we look at the results together and interpret together. And then, of course, publish and disseminate as a team, which is why you hear so many of us speaking today. Next slide, please. All right, so let's talk a little bit about science. And in the RFA that Angela mentioned, the focus was on creating planning trials that would be able to test the efficacy and effectiveness of recovery support services for people with medications for opioid use disorder. So the focus was very specific in the RFA to focus on people who are choosing to use medications for opioid use disorder as part of a recovery pathway. And that's what we focused our grant on too. And of course, our focus was recovery community centers. So let's talk about this specific focus. Next slide.
Yeah, so the starting ground, as you might be aware of, is the opioid epidemic. So the national overdose death rate remains unacceptably high. It has risen sharply over throughout the 2000s. And as you see, about 107,000 lives were lost in 2022 alone. So it remains unacceptably high, and something needs to be done about that. One of the things on the right-hand side, you can see a graph of the age-adjusted rates of opioid-related deaths. And in the recent years, the death rate has started to slow down amongst white Americans, which is the top line, but amongst Black Americans, which is the bottom line, it is still continuing to rise, which is a disparity that we wanted to address in our grant. At the same time, the current evidence demonstrate that medications for opioid use disorder, MOUDs, are very effective, but we also recognize that they alone cannot serve as a cure for OUD. That is where recovery community centers come in. So combining those 2 pieces is the goal of the project, and seeing if linking RCCs to existing MOUD providing clinics could confer further benefit. Next slide, please.
So we'll discuss what are OTPs, opioid treatment programs. These are the primary partners we decided to focus on when recruiting people who are on medication for opioid use disorder. OTPs are the primary avenue for accessing MOUDs, which might be changing with upcoming legislation. They have been around since 1969, and they are the only place you can currently get methadone, which is the most commonly used for MOUD. The Modernizing Opioid Treatment Access Act is a current effort under the way to widen the accessibility of methadone. And if this is passed, this would allow board-certified addiction doctors to prescribe methadone directly to their patients. OTPs are highly structured clinics that provide medications alongside psychosocial and ancillary services. Next slide, please.
Sorry, hi, good morning. So this is an opportunity to talk about what peer recovery support services are. And specifically, they're non-clinical services, which means that we support many of the services that outpatient programs provide. These are delivered by peers. So the non-clinical services are delivered by peers who basically are people with living and lived experiences. They're in large variety of settings, such as treatment, emergency departments, OTPs, and outpatient clinics, and also in peer-led spaces, such as the recovery communities, recovery homes, recovery collegiate programs, and recovery high schools. You will see a little later on how multifaceted the supports are that are provided by the peer recovery support services. And SAMHSA conceptualizes those services as those that address the recovery capital, the emotional, informational, instrumental, and affiliational needs. Next slide, please.
So how should opioid treatment program and peer recovery support services interact? There are actually published federal guidelines on this. So in 2015, the federal guidelines for opioid treatment programs strongly encouraged opioid treatment programs to include these other support services in addition to counseling. So these other support services were highlighted as peer recovery coaches, 12-step programs, and faith-based and community groups. And then relatively recently in 2023, this guidance was further established in the Treatment Improvement Protocol TIP 64, which was developed by SAMHSA. And I'm going to include these two links in the chat in just one moment. But this protocol specifically mentions recovery community centers. And you can see the text right here on the right, that this overall idea was that substance use disorder treatment program providers, supervisors, administrators, such as clinic and program directors, should offer peer support specialists for problematic substance use and ensure that individuals in or seeking recovery are aware of and can access these services, the services described above. And they go on to say that these settings can integrate a peer recovery coach into their own services, but importantly, that integrating the peer position into substance use disorder treatment programs should supplement or enhance peer support specialists that are offered by recovery community organizations or recovery community centers, and not replace them, it says. So this being that even though a opioid treatment program has a recovery coach, it shouldn't end there, and that a recovery coach could and should link a person in recovery to the community outside of that program. Next slide.
So sort of continuing on to that, we also currently believe that RCCs are being underutilized by MOUD providers. So from previous research that we've done on RCCs, we do know that they act as a hub for peer recovery support services in their communities, and that they are largely and completely supportive of medications for substance use disorder generally, and specifically medications for opioid use disorder. From our survey of RCCs across the nation that we conducted in 2021 and 2022, we found that 85% of RCCs reported having linkages to clinics that provide MOUDs, but we also found a significant proportion, 35%, were welcome to closer collaborations with these clinics. So to us, that shows that while there is great connection being made, that there is still room for improvement and room to grow these connections and make them closer. Next slide, please.
All right, so that brings us to the design of a study we are presenting today. Our research questions were simply, do OTPs, the clinics that provide medications to opioid use disorder, know about their local recovery community center? And if they do they provide a linkage? And if they've already experienced this, can they provide guidance of how to make this linkage work optimally? To this goal, we looked at the RCCs we had located nationwide, and we looked for RCCs that were serving Black communities, back to our original focus on that group. And the operation defined an RCC as serving a Black community if 27% or more of the residents within the zip code within which RCC existed are Black, as found in the US Census. So we found 47 RCCs nationwide who would fall under this definition. And for those 47 RCCs, we found their address, their physical address, and put that into the SAMHSA treatment locator. And you can see some screenshots from what that locator looks like on the right here. We literally put in the address, we flagged substance use, we flagged OTP, and then we would get a list of the nearest OTPs to that RCC. And we did that for all 47 locations that we were interested in. We then wrote down some details that the SAMHSA treatment locator provides for each of the OTPs it showed us, including the types of care and pharmacotherapies and treatment approaches that were being used at that clinic. Then we would reach out to the closest OTP and phone call them and send them a link to the survey. And if they completed the survey, we would invite them also to do an interview for us. So we have 3 sources of data: the data that we got from the SAMHSA treatment locator, the self-report information that clinic directors gave us in the survey we sent them, and notes on the interviews that they completed with us. Next slide, please.
All right, so for recruitment, it was a little bit more challenging than we might have anticipated. And those challenges stemmed from a few areas. So starting with the SAMHSA treatment locator, it only provided us with phone numbers, not email addresses. So these were a little harder to obtain. And so we would have to, reach out to folks on the phone, try to get the email, which sometimes they wouldn't be comfortable for providing. And then we would then try to provide them with the email with the survey link and information about the study. Another challenge was that the opening hours for these clinics can be limited. So that made our window of trying to contact these individuals even smaller. And then last, sometimes when we did get them on the phone, they just didn't know how to handle our inquiry, as we weren't trying to receive services. We were trying to engage people in research. We were trying to engage their clinic directors in research, which is even more challenging considering all that they have on their plate. And then our response rate was a bit modest. We had a total of 15 clinic directors who responded to our survey, and that's the data that our team will be presenting on today. And then going back to the response rate, the 15 OTPs or the clinic directors represent 32% of the locations that we targeted. And about 13% of the clinics that we contacted and called. And then for each location, we would call up to the 3 closest locations for each location that we were trying to target. And then looking over here on the right, the people that we did get, they were largely clinic directors or serving in roles of administrative coordinator or chief operating officer, clinical supervisor. And you can see here that they were largely white. 73% were white. None of them were Hispanic. And a few were in recovery themselves, about 13%. All right. And I don't need to say next slide because that's on me. So moving on.
So the question then is, of course, how representative are the people that we did reach? And fortunately for us, through the SAMHSA treatment locator, we had a lot of good data on what kind of services they offer and what medications they prescribe and so forth, so that we could make it a comparison to say, these are the clinics we reached, these are the clinics we did not reach, and are they systematically different? Are we overlooking something big? So we looked at 49 different characteristics that were different pharmacotherapies they prescribe, different treatment approaches they use, and different recovery support services they link to. And out of all those tests, we only found one that was significantly different. And as I might remind you, when we do statistical tests, there's always a 5% chance that the finding is due to chance alone. And amongst 49 tests that you run, each one with a 5% chance, that we would expect to find at least 1 or 2, and we found 1. So you may not want to overinterpret it, but the difference is in motivational interviewing. The clinics that we got were slightly less likely to use that, 80% of them, than the clinics that we did not reach, where 97% of them said they used that. We also made a descriptive comparison because, as you saw, we only found 15 clinics. So statistical power is not always the only power. And you say, well, what if there's a 20% difference in what services they're using. We looked at those descriptively. You find those on the right-hand side, and there's a couple more where the clinics that we got were slightly less likely to prescribe lofexidine and clonidine, which I'm not a medical person, so I don't know how to pronounce these. But they were more likely to use the matrix model, which is an evidence-based, very intensive treatment program, and to do 12-step facilitation. They were also more likely to have in-house housing services, and were more likely to have recovery coaches as part of their program. But those are not statistically significant, but leaning, more prevalent. But we did get, remember, 49 characteristics we looked at. There are very few differences happening. So we think that even if it's just 15, they're quite representative of the whole set of clinics. Next slide, please.
This slide represents the clinics we received information on. Each of these clinics had about an average of 29 paid staff members, all of whom said they did outreach to the community, which represents about 93% of them. The clinical directors was asked to estimate the demographics of the patients they are serving, and of particular interest to note is the percentage of Black patients they are serving, which was an average of 23%, which is much lower than the percentage you would see at NORA and DRP, where about 60% of their participants are Black. And it is important to keep in mind that these are similar communities. Next slide, please.
All right, so in our survey to directors, we then asked them about mutual help organizations and recovery support services. And in both cases, we first asked, are you familiar with these mutual help organizations? And they would check off which ones they know about. And then we would ask, well, which ones do you provide referral to with your patients in your clinic? And for mutual help organizations, you can see that 100% of the clinic directors were familiar with AA and NA, and 100% also routinely provided referral to their patients to go and check out AA and NA as they're navigating recovery. Now, we asked exactly the same worded questions about recovery support services, and we found that 80% of clinic directors, OTP clinic directors, were familiar with recovery community centers, which was excellent news, given that we thought it was much lower based on our Seminar 5 impressions and conversations we've had since then. So it's great news. People are knowing more about recovery community centers. Then we asked the same question about providing referral to their patients to check out recovery community centers. And here the number drops down to 67%. Which is surprising because it's 100% for A and NA, and here people may know but not feel comfortable to refer. Next slide.
Thank you. So what we just understood was that 80% were familiar with the RCC, but then when asked about the specifics of the RCC down the street, as reflected in the green box on the right-hand side, the clinic directors were presented with the name of the RCC, the address of the RCC, the website, and the distance from that clinic. And then specifically asked, do you know about this RCC? And 40% said yes. Of those that knew about the RCC, the question was, has your staff visited this RCC? And great news is that nearly 67% had actually visited the RCC, which was, in this case, less than a mile away. And then the percentage of the patients who actually hear about this specific RCC from the clinic was surprising here, that only 33.3% were telling 1 to 15% of those patients about the RCC, which was down the street from them. And the great news, though, because we do have positive takeaways here, is that the RCCs, 50% of the RCCs actually employ recovery coaches. And so the hope is that there's an opportunity to engage to help build awareness of the RCCs that are near the OTPs. Next slide, please.
A question we asked was why were the referrals not happening and what were the barriers? So all of the OTP directors 100% thought it would be valuable to tell patients about the RCCs and that routine referrals from clinics make sense. Next, we offered some barriers we've heard in seminar series and from colleagues in the field. The number one barrier OTP directors spoke upon was that they felt like they didn't know enough about the RCCs, with 47% of them saying that. There was also some concern about 40% of the OTP directors felt that RCCs were not a welcoming space for MOUDs, which is interesting to point out that we just saw that 100% of them referred and have heard about NA and AA, but historically NA and AA have not always been the most accepting of MOUDs. Excuse me. Another concern was that the OTPs did not have enough time, staff, and/or money to connect with the RCCs with 33%. Next slide, please.
All right. So then to expand on this further, we also asked OTP clinic directors to do an interview with our team so we could expand more upon what barriers they might perceive and some ideas and solutions they might have. And so when we were, well, I should say, we conducted 5 interviews and we coded them with rapid analysis. And the major ideas that came from this was that concrete specifics are needed and varied touch points are needed. So we heard that there is a need for more information on the specific services that RCCs provide. There was a request for knowing more about like the opening hours of the RCC, information about transportation, and how to access the RCCs via public transportation, as that was important for folks. Knowing more about the specifics about costs, which important to note that there's typically no cost associated with RCCs or using RCC services, but turns out that that needs to be clearly spelled out for people so that they know that ahead of time. But from what we heard is that people need concrete information about the RCCs before that they can feel comfortable or can actually go ahead and make those referrals. And then another barrier that you can see on our little word cloud here is that OTP directors and staff are finding that themselves are having a hard time managing these things, and that they would love to have more funds to coordinate all of these different aspects. So for instance, something that arose was having funding for a position to do that and hopefully make space for more recovery coaching time so that these connections can be done. But in general, as you can see here, they think that physical flyers would be helpful as well, as having RCC staff coming to present so that people are familiar at the MOUD-providing clinics. More funding would also allow for warm handoffs or soft handoffs to happen, which can really be facilitated when you have people at the OTPs that are connected with RCCs and have established connections with RCC staff. Right.
Perfect, thank you. So for our conclusions, I just wanted to remind you all that our sample size is small. We only got interviews from 15 OTP clinic directors. We do believe it's a fairly representative sample, but that is very important to keep in mind that it's a very small number that we are making huge inferences on in terms of the percentages we are seeing. It's also one person's view. Yes, they're serving in a coordinating and leadership position, but they don't know everything that's happening in the RCC and may not reflect all of it. So keep that limitation in mind as well. That said, so our percentage was pretty low in terms of referring of clinics that knew about RCCs was fairly high, but willingness to refer was 66% in the theoretical sense. And when it came down to actually knowing the RCC down the street, which was on average 9 miles away, that was 40%. And the RCCs, I mean, the OTPs that we engaged in our survey, if anything, they were leaning towards being more open to interaction. They answered our phone call and our survey. And also you saw on the SAMHSA data collected on them, they were more likely to have 12-step facilitation and have recovery support services already integrated. So if anything, these were our 40% represents the people most open to connecting to the RCCs. We suspect that this number might be lower, if not in the larger sample. Our findings, and the important part, and really the take-home important message for us is theoretically, it's super heartening to see that everybody agrees that yes, OTPs should make referrals to RCCs. It makes sense. And this was after they had really seen our long list of barriers that they might have, and we really cued them to think about these things. And nevertheless, theoretically, 100% of them agreed, yes, it makes sense. It should be a standard part of what we do. Practically, then, that's not what is happening. And this is why we started to brainstorm some of these ideas about how could these barriers be overcome. And that's why we're here presenting to you all to hear more about how we can work on overcoming these barriers. All right, next slide.
So specific to some of the concerns that were raised in the qualitative interviews that Drew outlined for us, we wanted to take this opportunity to talk about what RCCs are and what we are not, and how we complement working with OTPs and other medication use disorder programs for people with opioid use disorders. And so we are supportive. RCCs support people who use medications for opioid use disorders. We support people who are using harm reduction approaches and abstinence-based approaches as well. And that means that we're complementary to the OTPs. We don't bill and we don't counsel and we don't offer medication for people with opioid use disorders. And so therefore we are non-competitive. And what we do is offer holistic support for people and their families, and to help support the integration and reintegration into communities and society as a whole. And some of the ways that we do that are through social activities like drumming and dancing and knitting, cooking, art classes. We also offer alternative forms of medication like yoga and acupuncture, reflexology, tai chi. There's an opportunity for family support at several RCCs, and that may look like a parenting skills enhancement class or a bereavement group. And then we also offer community support in the form of naloxone distribution, naloxone trainings, mental health first aid, 12-step, and then specifically linkages to care, which could either be back to the OTP or any other support that can help an individual coming through. And then lastly, there's an opportunity for workforce development here. And so what that looks like, it could be, training such as OSHA, home health aid, scaffolding, or SERPA trainings. So that is who we are and who we are not. And hopefully this will help to build awareness and support between the OTPs and the RCCs. Thank you.
Beautiful. So the questions for you, we're going to be turning it over to Vinod to react to our study findings in just a moment. And while he is sharing his reactions, we also want to cue you up to think about these questions. And some of these questions involve, how would you best onboard people who are study participants to try out their local RCC? What would be best, what would be most helpful for them to learn about and feel comfortable walking through those doors? Then anything you have in terms of recommendations for how do we partner with OTPs and other clinics that provide medications to allow us to put study flyers in their waiting rooms, to tell their staff about our study and so forth. Any advice and tips you have for our study team would be wonderful. Because we are currently designing another study, which is going to be a small randomized trial where participants will either be randomized to a group where we are actively onboarding them to their local RCC or a group where we don't. And we would love to have any feedback and support as we are going through that study and setting it up and running it. And then if any of you are in connection with either an RCC serving a Black community or an OTP in such a community, do reach out to us. We would love to partner, have you be involved in this study in a way where if you're an RCC, you could provide us with a 4-minute video about your RCC that we can show to our study participants, or we can talk about how to recruit from your waiting rooms and so forth. So please do reach out if you want to support this study in any way and know more about it. All right, Vinod, I'm going to be turning this over to you. You are a clinic director. What do these findings mean to you? What kind of thoughts will go through your head when you see these findings?
Thank you so much for the opportunity. This work is really interesting and exciting for me. I'm I'm the medical director of the West End Clinic at Mass General, which is not OTPs often refer to treatment programs that focus specifically on opioids. Commonly, it can be referred to as methadone clinics, so not necessarily all of them provide methadone, many of them do. The clinic where I operate is a little bit different. And that's a general substance use dual diagnosis clinic where we take care of people with substance use disorders or history of that with co-occurring mental health concerns. But some of these results we're still engaged with similar challenges. How do we get our patients as much benefit as possible, whatever that looks like, whether we call it clinical treatment, community building, repair of family life, engagement with work, or other aspects of life that contribute to recovery capital. Also, I can represent myself. I have a limited sense of what some other programs are thinking about. So one thing is that I completely agree that there's a desire for close collaborators and working with people on recovery. Substances for medication for substance use disorder can be really, really helpful. Methadone and buprenorphine are known to be life-saving. That's a high bar, and nothing else, almost nothing else in psychiatry reaches that bar. But while that's great, that's not nearly enough. It's not just being on medications that does the trick in terms of getting people to where they need to be. And we don't have enough therapists. We don't have enough groups available or opportunities for family work. And we definitely need more community building, which I think is a particular role that RCCs excel at. I think one thing that I feel is that clinicians are going to hesitate to make recommendations to interventions that don't match well necessarily with patients' needs. It was interesting that, well, I'll explain this in a moment, but for instance, I've had a number of patients that maybe struggle with the idea of religion. Maybe they've had difficult experiences growing up with it. And when I might talk about, say, 12 steps, they say like, oh, there's a big religious part of that. I don't know about the higher power God thing. And knowing that, knowing their concern about that, I might be less inclined to bring up 12 steps for that particular patient because, well, it's not great for my for our relationship if I'm providing suggestions that they're not going to be on board with. One of the things that's really lovely about RCCs from that perspective is the real inclusiveness that all paths are welcome. Through opportunities like engaging with the seminar series in this project, I really understand like how universal that philosophy is and how welcoming they can be to medications for OUD. But I don't know that how universally clinicians understand that, and that bore out in the data that we were just looking at. A lot of people were suspicious that RCCs would not be as welcoming to medications for opioid use disorder. One of the striking things about clinicians is that they are very busy. There's everyone is, but clinicians are juggling numerous obligations based on federal regulation, local requirements. Sometimes if we're evaluating a new patient for our program, we have to spend a lot of energy evaluating tuberculosis risk or nutrition assessments, which are important, shouldn't be ignored. But in terms of like prioritizing what would be most helpful for the patient, the regulations determine more of our energies than we'd like them to. And so because of that, because we're managing that, sometimes there's less intellectual, emotional, cognitive bandwidth to keep in mind all of the opportunities that exist in the community. And so while we have, I'll say that I expect that the individuals in our clinic I know they've all heard about RCCs. We actually arranged to have the Massachusetts state leadership that helped to coordinate the RCCs to come to our staff meeting and talk about the program. I suspect it's a minority of clinicians that actually actively refer not because they don't think it's valuable, but they just might not have time or don't have the bandwidth. I think as we were having this conversation and listening, I was thinking clinicians need to get a large menu of things that can be helpful for people in their recovery. And so really, I think clinicians need to be convinced that it's better than everything else out there. There are lots of apps or online resources or places one might be able to go that frame themselves as helpful for people in recovery. But why are RCCs outstanding in the way they are? As much as we like to talk about, we practice evidence-based medicine. I think stories go a long way in terms of impacting behavior of clinicians. And I almost wonder whether when there are opportunities to have RCCs come and talk about what they do to either clinic leaders or the whole clinics at a staff meeting, I think bringing sort of like a peer champion that's been through the RCCs themselves can be pretty impactful in saying yes, I was the kind of patient that might have come to this clinic, and this is how the RCC helped me along my journey. I think that can be really impactful in terms of helping more people get there. The other important point I want to make, I have to go real quick, is that a lot of our care is delivered virtually now. After the pandemic, there's this move towards virtual care, at least in my clinic in Boston. People don't want to deal with traffic, don't want to deal with public transportation. They appreciate that we can do much of our work with telephone, video, and our clinicians recognize that I'd rather meet them sort of at home and hear what's going on rather than have them not come in for care anymore. So for better or worse, this is a greater part of the care that we're delivering. But because of that, we don't have the waiting rooms to fire in the same way that we used to. And I think plays a role in terms of how we can outreach. But those were a couple of thoughts I realized at the time. So let me stop there.
That's awesome, Vinod. Thank you, and definitely connects with some of our thinking about the next study we are designing. I just want to remind folks that we are almost at the hour. We are all going to stay here with the presenting team to chat with you about details and thoughts and ideas for another half an hour, but we are going to be stopping our recording in a minute. And before I do that, I wanted to make sure I thank you all for being here, and I'm looking forward to the conversation we're going to have in the next half hour. Thank you guys for being here. Cora, if you want to turn off our recording and then